Hi, good evening and welcome to Policy Exchange. My name is Robert Eade. I am Head of Health and Social Care here. We are really delighted to be hosting this discussion, which is considering how can we maximise digital technologies in the hospital of the future. I've got a really fantastic panel of speakers for the conversation, which I'll now introduce. So starting on the far right-hand side, we have Dr. Tim Ferriss, who is National Director of Transformation for NHS England. Tim had previously served as a non-executive director of NHS Improvement for 3 years, but the NHS was able to lure him on a full-time basis in May 2021 from the not-for-profit Massachusetts General Physicians Organisation. Tim is the inaugural NHS's Director of Transformation, and last week, I don't know if you spotted this, Tim, you were ranked as the 4th most influential person in UK technology. So that perhaps highlights the really integral role that you've got in driving transformation across the health service. Next to Tim is Sarah Thomas, who is the Digital Director of the new hospital programme. Sarah has 15 years experience in the private sector, specialising in healthcare technology, and has worked across digital transformation, including supporting the opening of Chase Farm Hospital in 2018, which was delivered on time and within budget, and is one of the most digitally mature hospitals in the country. The new hospital programme, which I'm sure Sarah will talk about, is the joint DHSC and NHS England programme to build 40 hospitals by 2030, with a further 8 schemes invited to bid for further funding. And then completing the lineup is Dr. Tom Hughes. Tom is a consultant in emergency medicine at the John Radcliffe Hospital in Oxford and the clinical lead for the emergency care dataset. Tom developed and introduced a new dataset for emergency care, which was successfully rolled out across England several years ago. His work in this area was recognised in being awarded an OBE in the 2020 New Year's Honours. Really keen to get your frontline clinical perspective. I'm going to invite each of the speakers to share a few initial thoughts in relation to the question, and then we'll go to questions from myself and the audience. It's a hybrid event, so welcome to the online audience too, and we're keen to bring in your questions too. So if you'd like to ask a question, please raise your virtual hand and we will bring you in when we reach that point. The final housekeeping point is that we know outside there's a lot of interest in the current political situation and the leadership contest. I'm pleased to tell you that this is a politics-free zone. Policy Exchange won't be endorsing any particular candidate. I'm sure our speakers won't be drawn to comment on the suitability of them and their healthcare prospects. So hopefully it will be a good opportunity to debate policy rather than politics for the evening. Without further ado, I'll hand over to Tim for his opening thoughts.
Well, good afternoon, everyone, and thank you very much for the invitation, Rob. And it's a pleasure to be here. When I think about the opportunities for the NHS to use digital to transform not just the way care is delivered, but also the relationship between patients and healthcare in this country, the opportunity is so enormous. Really, that's why, Rob, I had to come a year ago. That's what pulled me here. And very specifically, when I was on the board watching the formulation of policies around integrated clinical systems, the ICSs, ICBs, and ICPs, that's what sealed the deal for me, because in my work in the United States, as both a health economist and the head of the Center for Population Health at Mass General, I was constantly trying to create greater integration around the pieces of the healthcare system, which in the United States probably is well known, are separate businesses and are encouraged to compete with one another. The formation of the ICSs had a couple of really salient possibilities for me, where the delivery of health to a population could be taken to a new level. That is very specifically around the integration of health care providers. So within an ICS, thinking about a population and bringing continuity to the care among providers of health care. But really, and that's not new, but really the big opportunity is bringing social care into the same discussion and integration of providers of care, so that everyone is on the same page. across a population for an ICS of about 1.52 million people. That's the opportunity here. And digital is the vehicle by which you take advantage of that opportunity. So I think of continuity across the care of a patient in three categories. There's continuity of information, continuity of relationships, and continuity of management plan. One of those three is all about the information systems that underlie, in this case, an ICS. And so if that is a goal, which I believe it is, continuity of information, relationships, and management plan, and the integration across health and social care, well, okay, that's the distant goal. What is the proximate goal? What are the first three steps that you take that address today's problems? And today's problems are really significant. The capacity problems, I don't have to say much. You all are familiar with the capacity problems, both inpatient and outpatient capacity problems in the NHS. And so the question is, how do you design the next steps in the digital underpinnings of care that provides immediate relief to current pressing priorities, that also set you up for success for that integrated future across integrated delivery systems? So that's what I spend every day in the details of, and very much look forward to the conversation that we're about to have.
Thank you very much, Tim. I'll now invite Sarah.
Okay, right. So thank you very much. And again, yes, thank you very much for the opportunity to come and speak today, and certainly talk about a topic that I'm deeply passionate about, and I certainly get very excited about, the talking about the connecting healthcare, about the opportunity of digital, and about the opportunity of digital in how it can continue to enable healthcare. And I think it's also an opportunity to look at things differently and to be able to challenge the status quo. So the new hospital program is a transformational program. It's the way we're looking at it, it's really an opportunity for us to look at how we can build differently, how we can build more efficiently, and how we might be able to challenge the way that models of care are structured, and just disrupt that a little bit. And so for me, looking at this as well, and then my background is in the clinical and operational space, working with previous EPR providers, but now looking at this opportunity of smart buildings and learning and understanding and studying that estates and facilities management opportunity, and how we can bring the estates and facilities management strategies alongside the clinical and the digital to create that intelligent building, wrapping that data strategy around it, and really I think I call it the secret sauce, quite like that, of the program is really in the data. How do we ensure that we're deploying the right systems, connecting the systems, and gathering that data to create that complete patient pathway now, so that we can proactively react, that's probably not quite the right way of saying it. So how we can be proactive versus reactive to the environment, and manage our hospitals in real time. So the other challenge we have, these amazing buildings that we're going to be designing and delivering there's a lot of characteristics within them that we have to consider. So for modern health, the delivery of modern healthcare. So it's about flexibility, sustainability, scalability, interconnected and intelligent. So how do we ensure that we're building that technical infrastructure that enables us to support that, but also not just for today, but in the future? We all know that technology is changing rapidly, it's always changing, And so we need to ensure that the buildings that go up can continue to flex and move with those innovative technologies that are coming down the line. We also recognize that the trusts that we work with are part of a much wider health ecosystem, and therefore it's important that we remain fully integrated with the agendas across NHS transformation. It's a very complex landscape, and vitally important we do not miss the opportunity to make the right decisions when it comes to interoperability. And then last but not least, definitely not least, our patients and staff. So remaining firmly at the heart of our design approach is patients and staff and their experience, and we need to consider how people will communicate with their hospitals, how they will navigate and access information, and improve staff experiences by designing safer environments that make it easier and simpler to do the right thing.
Thank you very much. Can I ask just one follow-up? Because you mentioned standardisation, and I know that there's obviously a desire to build at a good pace. What's the standardisation offer around digital care, and how do you kind of square that with sometimes a desire to have bespoke solutions in a particular hospital for the specific thing that they need?
For me, the way we're looking at standardization is really understanding that baseline of technology that is needed to create an intelligent hospital, if you will. I think I personally, and the way we're thinking about it at the moment is that don't want to go down the route of too much standardization, because you don't want to move away from the opportunity for innovation. But I think that leveraging the standards that are being set by the wider NHS and looking at the standards of the future, I think we through development of best practice, we could probably continue to innovate through that. I don't know. Sorry, I'm sure. I think that answered your question. Mm-hmm. Sure.
Mm-hmm. Great. Tom.
Hi, and thank you again for the invite. So I've sort of ended up in this job by accident and through a number of happy circumstances. And so I trained partly in the UK, partly in Australia. And coming back to the UK in 2005, I was really struck by how little we knew about my area of care, which is emergency care. And so we went through various iterations of trying to get better data about it and understand what was going on. One of the turning points was in 2013 when there was a parliamentary select committee report which said we're flying blind in this area. And so we've been spending a lot of time trying to fix that and sort out with the data so that you can actually see what's going on. And the reason this matters is that when, dare I say, as dinosaur clinicians when we started, then at that stage in the UK, then 50% of your hospital admissions came via the GP, and now it's 10%. All of these patients are coming through the emergency department, and the acute care. So emergency medicine or emergency ambulance is a relatively small beer within the NHS. It's about 3%, 3 billion, something like that. But it's the gateway to 50 billion worth of acute healthcare spending. And so not understanding it is a bit of an own goal. So anyway, I was also director of, acute care director for a project that some of you may have heard about called Hinchingbrook with Circle. And with a data-driven strategy to improve urgent emergency care there, we went from being in the bottom quartile in 2012. A year later, we were top in combined friends and family and the 4-out standard. So data-driven, you can use the data much better in acute healthcare to understand what's up with your patients and where you should be sending them. We tend to view data as a passive thing about understanding how things have happened, but we need to get much better at using that data to say, well, I've got a patient who's got this condition. I know that they're going to need these resources, these people, and the data can actually support that decision making and direct the right patient to the right place in the first, at the first port of call. And so this has been a bit of a journey, and as of next year, then we will have ambulance, emergency departments, urgent care centres, and then same-day emergency care. So this is the care to keep patients out of hospital. We'll have that coded in the same framework so that you can see where we should be spending money, because I'm fairly sure that the new Secretary of State will be saying there is no more money. And we need to make some hard choices, not just about where we spend money, but also where we don't spend money. And to do that equitably, we need good data. Thank you.
And if I may, just another follow-up. When you introduced, it'd be good to hear a sort of practical example of where the data set has taken you from when you first introduced it in 2017. What are the kind of coding instances that you fully understand now as a team when you're planning a busy day at the RAGDEV?
Well, so one of the important things, data is, talking about data is a good way of putting people to sleep, but an example about how equity can be supported. So prior to putting in ECDS, the emergency care data set, then the mental health attendances in emergency care were 0.5%. Now that we've got ECDS in, it's about 4.5%, and that's in line with international standards. And so if you don't collect data, then you are artificially selecting for groups of patients who are the most difficult to identify for caring, the homeless patients, patients with addiction issues. So we need to be able to see if we're directing care, if we know now that we have about 5% of our patients have mental health issues, and we need to make sure that we've got the facilities and the people to support them and manage those patients. But unless you can see what's happening, you won't be able to do that. And data completeness is not a nice thing to have. Otherwise, you will miss out the most vulnerable members of society.
Thank you. That's a really good example. I might come back to you, Tim, if that's okay. The NHS has obviously made quite significant progress on virtual wards during the pandemic. I know that's something you've spoken a bit about. And we've seen kind of some of the opportunity around respiratory and heart disease, etc. But what do you think is the plan for virtual wards moving forward? How big could this get?
So I want to put virtual wards in a wider context, which is the context that if you look at the arc of the delivery of medical services, what's happened over time since the 50s and even before is that we, the people who deliver healthcare, have been elaborating more and more specific services and getting better and better at delivering that specificity to meet the patient where their need is. The virtual ward is just one more extension of the fact that, in fact, an emergency room physician or emergency department physician has a limited set of choices, has always had a limited about what happens to that. And in its most basic form, it's dyadic. You send them home or you admit them. When in fact, human illness forms an enormous spectrum of complexity. And so what the virtual wards is really just another option for the right patients. But what's important for this country here and now is bed capacity is at a premium. That I hope that's not news to anyone. And so to the extent that virtual wards can be specific for a subgroup of those patients who are hospitalized today, but can be safely managed at home. I'm going to give some really simple examples. So this is about safety, right? So antibiotic delivery for cellulitis in a diabetic foot ulcer, very common admission. It is extremely rare, almost unheard of, for that actually to be a mortal event for someone. But why do they get admitted to the hospital? Well, because we have to plug them into IVs and deliver IVs, and it's just much more convenient for us to do that in the hospital and organize around hospital care than it is to deliver it to their home. Well, actually, it turns out that with modern technology, particularly monitoring devices and ability to communicate in real time if someone needs some help, in fact, you can do it at home for 20% cheaper on a all-in cost basis, much lower carbon footprint, and by the way, patient satisfaction goes through the roof, because wouldn't you rather have your cat curled up on your bed getting your IV than be in the hospital, potentially with 5 other people in the room, with not a whole lot of privacy, and maybe someone in your family cooking for you. Okay, so I mean, I set that up, right? But it's pretty obvious, and actually, the virtual wards have been. We have tons of reports from patients who are just thrilled that they had this option to go home and get care, safe care at home that delivers them the outcomes that we all want. So, where can this go? Well, there's 2 answers to this question. So there's a specific SR settlement that has an investment that we have aspirations for delivering a certain number of beds. I apologize, I can't remember off the top of my head what that number. It's a published number, but that's not what our aspiration should be. Our aspiration should be that every person who could benefit from being hospitalized, from getting hospital level care outside of the hospital, should get that care. And I'm going to close by just saying, so how do we know what that is? Well, we don't know what that is now, but we will with the right data. And this is where the data issue comes in, because we need to denominate our data not on where we were last year in the budget and how many beds we had, virtual or otherwise, based on the budget from last year and the budget for next year, which is sort of the way we plan mostly. We really need to make all of the planning, structure, process, and outcome based on populations, and have, say, what is the number of beds for a age-adjusted population? What is the number of beds we need in this place? How many virtual beds do we need in this place? And so we should be planning that way rather than budget to budget, based on population need and the best possible health outcomes. It may surprise you, that's not exactly the way we do it right now. And so there's an opportunity there.
Fantastic. Yeah, well, that's also a nice bid to the new Chancellor, maybe, to think outside of single-year planning settlements or funding settlements for the NHS.
I didn't say that.
Well, I'm also, as the owner of 2 cats, I was very excited by your vision that you set out. So, Sarah, can I come to you? When you're planning and thinking about the new hospital design, how does that digital component in the hospital at home factor into your thinking in terms of working with the 40 sites?
Oh, very much so. Virtual care is and consideration for that is definitely part of our core design. And coming back to your question around standards, but if we're thinking about models we would want people to follow, we would certainly be expecting to see a virtual, how our hospital's going to be incorporating or looking at or planning for virtual care, and how can we use digital to enable that virtual care. And I think we look at it from a perspective of from productivity as well. So how does it enable the buildings that we're looking at to improve that patient throughput and that productivity through the fact that we don't need to bring patients into the hospital. They can be cared for outside of the hospital, but also maybe move home a bit earlier than they do now, spending more time in hospital when we can actually get them and they can be monitored at home, and therefore continue to increase that throughput and that productivity. And managing that from the data side of things is that real-time data gives you that opportunity to understand what is happening within the building, and on that, in that virtual model as well. So yeah, very much so.
That's excellent. Tom, feel free to kind of chip in on the virtual wall point, but I was quite struck by something you said in your remarks around data will show us when we need to make difficult choices to ensure that we make the right ones, so that we don't increase health inequity or whatever. Is there anything in your instinct or from your work in the emergency departments that does identify those areas where difficult choices can be made? What are the kind of breadcrumbs that we're following at the moment?
Well, so I think there's a lot of people have a lot of options, and that's good. but at the same time, we need to be able to see what is effective and what isn't. So an example of that might be, so you think people aren't going to turn up to the emergency department just for fun. However, when they put in, so you may remember these things called walk-in centres, which came out in 2000, and they were a big thing, part of a policy initiative. And it took us about 5 or 6 years to realise that actually they didn't work, or rather they didn't do the things they were supposed to do. So they drove process, or they drove footfall, but they didn't improve health outcomes. They didn't reduce the number of patients going to ED. And so unless you, so this was, the evaluation was published in I think 2006, 2007. It's taken us about another 15 years to shut them all down. And I don't think we've done that all, but so without being able to understand, you know, what is the value generated by these processes, then we're not able to put the resources in the right place. And so Muir Gray is one of the main champions of this in the UK, and he's been beating his drum to not a lot of attention over the last probably 5-6 years, but what his mantra is, it's always when the chips are down, when the economy's not going so well, then everyone's interested in value-based care, and it's also partly from Michael Porter from America has driven this. And it's about understanding where we should spend the money. Another practical example in emergency care is my daughter got sideswiped by a car, and she had a wound over her elbow. And so I took her to the local minor injuries unit to have that sutured up. But in fact, what happened is they just put the steri strips on, the paper sutures. And one of the things that you know as an emergency physician, I didn't go in with her because you know, no one likes people looking over their shoulders. But the thing about elbows is they tend to bend and they tend to pull the skin apart. And so that's why if you've got a wound on the elbow, you always stitch it up. And so I drove her back home, and before we got home, these paper stitches had fallen off. And so I had to then take her to an emergency department to get it done properly. Now, both of those interactions would have been recorded as successful, and both of them would have been paid for. But actually, if we're going to change where we should be spending the money, we need to get a lot better at identifying where patients should go in the first place and directing them to the right place.
Stitch in time saves knife.
Yeah.
Just to change direction slightly, Tim, I'm keen to ask you a question about procurement. Because obviously we've got some suppliers of innovative products here in the audience, and I'm sure online as well. How do you think the NHS does make good use of its status when it comes to working with suppliers of digital tech? And if not, where could it potentially improve? So
I spend a lot of time thinking about this and working on this, and in fact today was our kickoff of a ministerial commitment to improve our relationships with industry by explicitly talking to them more. So we had a meeting, our first meeting of our new diagnostics advisory group, and it's about several things. It's about better signposting to industry what it is we need, and it's also about providing more explicit avenues to them about where do they dock in. I constantly am getting approached and saying it's just so opaque and complicated. How do I have a productive conversation? Where do I go? And so we're trying to get better at that. And very important to understand like why that's really important is because innovation is going to be the way out of our sort of current capacity challenges. We are not going to do it by doing more of the same. Doing more of the same it is not affordable, and it's actually not the best possible patient care. And so there is a ton of innovation going on inside of the NHS. It's very gratifying to me every Friday, or almost every Friday, I travel somewhere and go to a trust somewhere in the country, and this country has extraordinary innovation going on, and there's that old saying, the future is here, it's just unequally distributed. Well, in my opinion, most of the problems of the NHS have actually been solved somewhere within the NHS. They're just not shared or spread. That's a piece of it. That's internal innovation, and that's the NHS becoming a learning organization and a spreading organization. That's sort of another topic, but external innovation, sort of on the commercial side, is a critical piece. And I'll just say, so how lucky are all we that the vaccine industry innovated and created new vaccines for COVID. You know, we're 20 million lucky, if I understood the publication from last week correctly. And industry has a lot more to offer. We have to do a better job of providing a platform for rapid cycle innovation, for testing, because it's got to work. It's got to work for us, and for adoption and deployment. I do have some hope that when ICSs and ICBs are purchasing, there will be 42 in this country rather than 168 or 212, however you counted CCGs. I think that's going to be better. I think our signposting will be better. I think our horizon scanning will be better. So we need to up our game. We're working on it. And then I guess maybe I do need to address the purchasing power issue. There are more opportunities for getting better deals. I just want to say that that's always part of over a contract. And what are the people who want to sell into us getting from it? What I've heard they're excited about is fewer discussions. Just if we could just have greater clarity about what we're asking for, that would help them enormously. So for example, on our EPR vendors currently get literally hundreds of different CCGs and trusts telling them, I want this, this, and this. There is no national list of what our priorities are. What the vendors have said was, in exchange for fewer conversations and more clarity around priorities, they would take that exchange any day. So I think there's a real win-win here for our relationship with industry.
Okay, when you said fewer conversations, I saw a lot of nodding heads in the room, so I think you're onto something there, Tim. Sarah, if I could just come back to the new hospital programme and think about the new estate. One thing that we haven't perhaps talked about as much is the potential for the new buildings to further us on our journey to becoming a net zero health service. I know the NHS, I believe, is the first health service in the world to make that kind of ambitious commitment. Yeah. What's the opportunity there?
I think we have an amazing opportunity there, and we're certainly building that strategy. I think it's very much within the smart building estate, understanding the use of building management systems to enable and also the intelligent energy systems to help us to proactively monitor these buildings and ensure that we're using them in the most efficient way possible. And also linking, interestingly, back to the virtual care model, but that opportunity as well for providing that access or different access to healthcare through a virtual model, meaning that staff, not just patients but staff as well, don't necessarily have to travel the distances that they do today, maybe unnecessarily to pop in to see a patient because they're deteriorating. You can observe that from home. So I think there's lots of different ways we can approach this. It's certainly complex, and it certainly is quite a massive agenda. But we are excited to be exploring the opportunity of technology within these smart buildings. Yeah.
Tom, I'm going to give you one last question, but then we'll come to the audience. So for those, I can already see we've got some questions coming in online. So if you do want to ask a question, you can prepare it. And for the online audience, you can raise your hand now. Tom, I want to ask you about staff. I imagine that clinicians have different perspectives and willingness to adopt new technology and to undertake coding. How do you win over the skeptics in your team?
So yeah, I think this is a real problem. Is how to engage people. So in the States, then if you don't do your coding, then you don't actually get paid, and so that does tend to concentrate people's minds. And so we don't have any particular characteristics from that point of view, and so it is appealing to people's sometimes better nature, but actually saying from a clinical care point of view, we need to collect good data so that we can tell the next person in the chain what's gone on and why you've done what you've done. And so from a clinician point of view, what matters often is usability. And so we did a survey which was published last year. It's online on the EMJ, and it turned out, so this is looking at the usability of the IT systems in emergency care, and it probably, spoiler alert, none of them met up to accepted standard of usability. And this matters because when we're talking about 26 million patient episodes coming through emergency care, then 1 minute extra works out to about £20 million, and therefore it's not a small amount of money if you have a system which is very user unfriendly. And so what we've done is try and make it as user friendly as possible, but it is still quite painful. And there's some things that you can't change, like some of the consultants of, let's just say, my generation with the sort of hunt and peck keyboard action. There are things that we can do better in terms of voice transcription and helping. The technology can help very much with that kind of things. And in the same way that Google does predictive text, then I'm sure that we can do better in terms of documenting, collecting data. So I think there's definite opportunities there.
Great. We'll now go to the audience for questions. So if you could please raise your hand if you'd like to ask a question, and then the microphone will come over. So we've got 2 questions just here on the row there. So the gentleman at the back and then the gentleman in the second row from the front. Just keep your hand raised up so our microphone can spot you. Oh yes, thank you. Yeah. And if you just could mention your name and organisation.
Yes, my name's Tony Bourne. I'm a non-exec at various healthcare providers. Spire Healthcare, Barchester. I'm on the board of CW. I chair CW Plus, which is the Chelsea and Westminster charity. Everyone has been rightly very excited that the pace of adoption of innovation dramatically speeded up during the pandemic. And I just wondered, is it without the spur of national emergency, is it going to sort of slump back to its old pace, or have we sort of got over a hill now? And then I think, Tim, you referred to entrepreneurs are baffled by where do I even go, where do I start? There are so many schemes, clinical entrepreneurs, NHS Digital Health Accelerator. I think entrepreneurs are completely befuddled about where to go. When will we have more centralized, more standardized procurement, and therefore pull through, rather than small SMEs who can't afford the shoe leather having to win the battle house by house by house, which is how it works at the moment? And when will we get over you must go away and come back with the evidence, go and do a trial, come back with the evidence, and allow people to come back where it's not life-threatening, with just a very good proof of concept that looks really good. It seems to really work and be incredibly helpful. Let's test bed it now properly, and we'll do the trial. So a few questions about the impediments to innovation.
Okay, thank you, Tony. We'll go along, starting with Tim, so you can respond to the different elements there. There's quite a bit to tackle.
Well, I think in part the questioner answered his own question. There's cultural challenges, and they're rooted in some really legitimate, important considerations, and that has to do with. So I'm not being defensive. I completely agree with you. I should have said that at the start. In commercial entities, rapid cycle innovation, agile ways of working, there's like hundreds of business books written about this, and the tech sector, the global tech sector has taken those principles to an extraordinary level where innovation occurs at an extraordinary speed. If you do something wrong in a data sandbox, no one gets hurt. You just do it again. And so healthcare is a little different that way. And so we do need rapid cycle innovation, and we do need sandboxes, particularly for tech in healthcare. And we do need open, to a certain extent, open architecture. And what I mean by that is, these are trite phrases, but free the data, right? And let people who are good at using data, who are not in the system, play in the system. That requires creating secure data environments that allow that to happen, or there are all kinds of tricks to make that happen. We need an infrastructure that helps that kind of innovation. That's not the whole answer, but it's part of the answer. We also need an approach to innovation in the delivery of services, and here I'll be maybe a tad more controversial. What I just said is sort of obvious. And that is, we need to have confidence that we will identify problems as we iterate on a particular innovation and fix the problem in real time. That is not, I'll just say, a typical, what's called a big design approach is you have the engineers think of every possible thing that could go wrong and mitigate every possible thing and then start the project, right? And of course, something goes wrong right away that they didn't think of, because you can't think of all the things that go wrong. Just coming back to your question, what the pandemic showed us is sometimes things are so urgent, you just need to get started and have the confidence that you're going to measure anything that goes wrong and immediately address those things that go wrong. Expanding that, you put your finger on it at the start of your question. Expanding that to a non-pandemic situation, I would argue there are some things going on in our ability to deliver healthcare that meet that test, honestly. The preventable mortality from cardiovascular disease in this country meets that test to me. Like, we should just be rapid cycle innovating and addressing these with all due haste. Same with early diagnosis of cancer, right? So there's a few big issues that we face, which we should be, the life sciences vision actually, and that was the vision for the life sciences vision. I'm sorry, I'm going on. I could keep going on. I'll stop now.
Would either of you like to comment on that point, or we give to other questions?
No, I think one of the issues is that there's a culture clash, if you like. So if you've probably seen Mark Zuckerberg, who's standing in front of a poster saying, move fast and break things. Well, within healthcare, then breaking things isn't particularly good. So there does have to be appropriate safety nets. And at the moment, then medical devices haven't been a target or a vector for WannaCry and the events, but they will do, and they're a portal for entry, and so they do need to be locked down. So we have to have an appropriate amount of caution on this. It can't be the wild frontier. But and I'd just like to say I didn't plant this gentleman, Mr. Bourne, but I am a medical director of a company that does we built a platform which does do what you're describing and allows people to iterate, but it's a really difficult problem.
Yeah, I was just thinking I'd like to pick up on the point about the speed in which I think it was the first part of your question in terms of how do we ensure that we don't fall back into old habits, if you will, and I think that's definitely really important to think about, because I think it really is quite easy to go back to what it was, or it's just a bit too difficult to keep going at the pace of change that we were doing. And I think it's all of our collective jobs to keep that energy moving and not forget the art of the possible and what was possible to do when we all put our minds together and we had the passion and the reason behind something to achieve. I think I personally was part of some population health rollout across London before pre-pandemic. So we all refer to pre and post-pandemic now, don't we, in our lives? But it was at the time the struggle to get the adoption or the art of the possible across. So it's too difficult, we can't possibly, and we've got to have meeting after meeting after meeting. And it was a 12 to 18 month plan to deliver. Pandemic hit, and they had a plan and rolled out in 2 weeks. And it was exactly the same products. It was exactly the same solution. So I think it's really important that we keep of the voices loud that say that it is possible and we must keep moving forward. But I think we have a role to continue to move forward at pace and making sure that we keep that pace going. So within the new hospital program, how do we continue that momentum and keep?
Well, the government's giving you a pretty tough deadline,
so
that pace has got to come automatically.
And you're going to now do a follow-up on that one, aren't you?
I'm keen to get some questions online because we've got some. So I'm going to take a couple actually. So first we've got Sheena Astana, and then we'll go to Christine Elliott. So Sheena, we'll unmute you, and can you try and ask your question?
Yes, thank you. Can you hear me?
Yes, we can.
Great. Okay. I share the panel's vision of a sort of future healthcare system in which care is centred around the patient's home, and we're doing remote monitoring, and we've got apps for self-management, and a whole load of different innovations. I think environmental sensors, various home sensors. I'm really sold on that, and I see the home as being the kind of future centre of healthcare. However, I am in an ICS which currently does not, 3 out of the 4 hospitals don't have comprehensive EPRs. And it strikes me that if you're actually going to integrate, rapid monitoring, remote consultations, virtual wards, etc. properly, you need to have a platform for that data to go to, which is difficult for trusts that are, I think, left behind. My observation would be that of the 27 trusts in the country that don't have comprehensive EPRs, a remarkable number of them are in peripheral coastal areas. And I'm concerned that, Tom mentioned the role of coding comorbidities driving the resource allocation formula. I am really concerned that that's been a sort of unintended consequence of using our diagnostic-based coding. So my question, sharing your vision, my question is, what can we do to level up these areas? Or do the panel think that such areas need to be leveled up? What can practically be done to level that up? And thirdly, it's not, I think, in my opinion, just about EPRs. It's about the whole digital ecosystem. So if you don't have that basic infrastructure in place, you're less likely to have the whole testing, rapid cycling, evaluation, the staff development, things as advanced as in some of our urban areas, which are really galloping ahead and actually getting government and industry investment. So I'm worried about a digital divide. I think it's holding back the kind of future that we're all envisaging, and I'm wondering about what we can do about that.
Thanks, and we'll go to Christine in a moment, but Sheena, where in the country are you from? Just if you mentioned that, because you mentioned there was disparities in your patch.
I'm in Devon, but there are other, if you look at Norfolk, Kent, Cheshire, there are places. I also contributed to the Chief Medical Officer report last year on health in coastal communities, and even I was surprised actually by our results. I really wasn't expecting to see, the extent to which lower life expectancy, and particularly outcomes for children and young people, were affecting coastal areas. So I'm getting a bit of a thing about coastal inequality, but I'm worried that digital inequality is exacerbating health inequality in coastal areas.
Thanks, Sheena. We'll go to Christine Elliott, please.
Right, okay. Yep, that's good. First of all, just briefly, there is a kind of under the radar unit within the Home Office called the Accelerated Capability Environment, which has some great learning, Dr. Ferris, on procurement with industry. So just point you in that direction. My question is, and I chair a large healthcare regulator, what do you envisage for the involvement of patients and service users in service design and transformation? Thank you.
Great, really great question. Okay, so just to recap then, so EPRs, levelling up access to digital divide, particularly looking at coastal communities, and then what about the involvement of patients when we're designing this stuff? Tim, maybe come to you first.
Well, the EPR one, it seems like that was a softball delivered underhand, because that was the greatest concern of mine when I arrived a year ago. I did not expect that there were trusts in this country that did not have an EPR. I was quite surprised to learn that. There are 32, and three of those 32 have gone live in the last several weeks. We have a plan that was announced in January, funded plan to make sure that every trust in this country has an EPR, has at least signed up by this time next year, and is implemented by the year following. I am personally calling every single CEO of every single one of those hospitals, and to the questioner who said she was in Devon, I will be in Devon next week to have that discussion. Every hospital must have an EPR, and we will deliver on that because we have to. Everything else that we want to do in transformation depends, just as she said, on having those basic building blocks, and we've got to finish the process of implementing those basic building blocks.
And do you feel like that sense of that digital divide then in terms of care and outcomes between those non-EPR and EPR?
Yeah, it's both. I mean, all of the you can't count avoided things, which is a challenging thing, the counterfactual. But everything we know from research suggests that care is less safe in organizations that don't have an EPR. That has been documented in dozens and dozens of studies across many different countries. The other thing is there is at least 15, sometimes a 25% difference in efficiency in the productivity and efficiency of organizations that have an EPR versus one. So from every angle, it's the right thing to do, in addition to the fact that if you don't first digitize the data, then you can't do clever things on transformation. So there's just, there's no debate. There's only a debate about the how and the when, and from my perspective, it needs to be as soon as possible.
And on the point around patient involvement, did you have anything on that?
Yeah, so one of the things that I really have enjoyed about being here for the past year is the extent to which patients are involved in so many aspects. So at every committee that I am a part of, every board, there are patient representatives. And for example, just the NHS app has a whole citizen input process to design, testing, the user experience. And so I'm sure there are always other opportunities and opportunities for more, but at least from where I came from, where that was sort of a novelty in the US, I find it much more consciously baked into the design of processes here than it maybe everything's relative. We still have a long way to go here, but compared to where I came from, we're in pretty good shape.
Great. Sarah and Tom, I'll come to you, and then we'll go back to the audience for a couple of questions.
On the topic of EPRs, yes, I think that, well, for me, within the new hospital program, our assumptions are that the trusts will have EPRs implemented through the frontline digitalization program that is in place. It's a fundamental part, a fundamental building block to then moving on to that intelligent hospital space of how do we then, we're interested in understanding how you take it beyond the EPR and how we're integrating even further in the data to like I said earlier, bringing the states and facilities management into that space and really joining up that pathway. So I absolutely agree, and my background is from an EPR provider as well, so deeply passionate about the importance of EPR. So we will be working alongside the frontline digitalization program to ensure and give our trusts the best guidance possible in terms of support and help in figuring out and building that digital strategy that will take them further, sort of now over the next 3 years to then at the point where we're building those buildings that we can then take it then from the next point on. But yeah.
And what about involving patients and the public in where our new hospitals are based? Because they tend to have strong views, don't they?
Oh, they do, and we're always they're very much at the heart of what we are designing. We have a patient advocate group that is involved in the new hospital program, and that's been pulled together by our clinical work stream. And they meet quite regularly to share the thoughts and ideas of the new hospital program, but also to get the input from the patient in terms of what they would be expecting from and how they would be expecting to interact. Yes, most definitely.
Great.
So on a personal level, then trying to deal with all the different suppliers. So with the emergency care data set, that's 175 hospitals, acute hospitals, plus about sort of 300, 400 urgent treatment centres, 40 different IT suppliers, and just the pain of trying to deal with all of these different suppliers, and everyone's got slightly different ways they want to do things. So a bit of standardisation would go a long way in helping resolve some of these issues. The only other point I would make is interoperability, which is really the key to a lot of this. Then you look back 20, 30 years ago and they're still talking about interoperability. And so it's not a technical problem, it's a political problem, it's a financial problem. But it needs some hard legislation to say this, you must play nicely in the sandpit. We call them sandpits, not sandboxes.
Great. I'll get back out to you once. We've got quite a few hands up actually. Can we take the two gentlemen at the front, please? You then, thank you. And then I'll take one more. So I'll take Richard in the middle there after. You could introduce yourself, please.
Hi. Yes, my name is Paddy McGuinness. I am a co-founder of something called Oxford Digital Health, which is a virtual medicine system. I'm also a chair of trustees of St Joseph's Hospice in Hackney, and I'm a former deputy national security advisor who sat at the head of the Cobra table dealing with Drydex attacks on GP surgeries and WannaCry, and been a bit of NotPetya too. And you'll see where my question comes from. Fantastic panel, and really, every strength to you, and the way in which you're talking about things is very exciting, whether it be standardization or the way in which you're pulling things through, or Tom, the way in which you're talking about the data set. Security wasn't mentioned much. I'd suggest to you that alongside a pandemic, the other thing that's going to change what you all do is if we have a really significant ransomware attack beyond those we already have. If we were Ireland and lost control of a chunk of our data. And so I'm very interested, because WannaCry drove our choice to go Microsoft for 1.3 million Office 365 licenses. I'm really interested in how you get both improvement in patient care and efficiency and maintain security out of your existing spend. Given that you've already spent on Microsoft, you've already got the national tenant, so you've got lots of opportunity there. How are you going to pull that through? Because that's a fact, and quite a lot of what you're describing is something you've yet to get the money for, something you're going to find it difficult to deliver. And it applies incidentally as much to an individual new hospital as it does to an entire system. Tim.
Thanks, Paddy. If you could pass the microphone behind you directly. Great.
Thank you. Isadasa Patel. I run a health tech company, it's a government-backed company which focuses on medicines management in the community. And actually, I was previously an advisor to the NHS Digital on COVID oximetry home and COVID virtual wards. So it's great to see virtual wards and remote monitoring, as well as data being given such prominence. But obviously, with data comes the big challenge, which you touched on, of interoperability. And so in the thinking around the new hospital programme and more generally, with the transformation happening right now, how can we promote and push interoperability and put it at the forefront of the agenda? Because to give you a concrete example of what that means for a patient, in the space that we work in medicine management, often the people are in and out of hospital, they're on reablement pathways, typically older, frail populations, and they're having to retell their story every single time when they move between care settings. And one big challenge we have, and actually the NHS on their website calls it the innovative red bag scheme, where the patient will come with a red bag of all the medicines they're taking, and they're having to explain to their carer why they have them, and then probably their GP, and when they end up back in hospital, they have to tell the hospital what happened in the care setting. So how do we, it's a huge problem, like you say, it's been talked about for the past 50 years, how do we resolve that?
Thank you, and then we'll just take one more question just in the middle of that row there.
Thank you. Richard Darch. I'm with Arcus, which is an advisory consulting practice focused on healthcare. I just wanted to link the comments that were made at the very beginning between Tim, Sarah, and Tom, and Tim, your comments about beds, and we don't have enough beds. I mean, the one thing that a patient does not come into hospital for is to be in a bed. They come in to be treated and diagnosed. Well, hopefully the other way around. And it's important to get those areas right. And if you look at the data, and particularly the front door, the emergency admissions, that most of those patients will stay around 72 hours, the vast majority. And so that starts to inform the configuration of the front door of the hospital. And most of those patients will be in just a handful of conditions. So it also focuses on the organisation of that front door of the hospital. Similarly, at the back door, we have a significant amount of capacity taken up by frail elders, which actually shouldn't be in hospital at all, or at least they should be moved on very quickly into more appropriate settings. So my question or observation is that, because I hear from the panel, and I know that you're all rightly focused on that transformation, and that comes across very strongly. But is there a challenge with the labels that you're given of a new hospital program, which is very hospital acute focused, and electronic patient records talking about patients, and whether we should be thinking about citizen health records and health infrastructure, which covers physical and digital infrastructure, and that infrastructure that should appropriately exist out with the hospital. So I suppose it's a comment more than a question really, but do you feel sometimes challenged in a high bound by your labels that are given to these programs, which also then encourages silo thinking and silo funding, when actually what is required is for transformation is something which joins those funding pools together.
Great, thank you. So just to recap, Paddy was asking to what extent is security central to a lot of the transformation plans. Issa was asking about the continuity of information, which I know is something you alluded to in your opening remarks, Tim. And then Richard, do we need a sort of new, richer taxonomy for describing transformation so we don't end up stuck in the old silos? So over to you, Tim, first. Stab at those.
Wow, those are meaty. Yes.
We can run until 9 o'clock.
I think I might need some of that wine back.
So, cyber. So you're absolutely right. It's not a question of if; it's a question of when. And the infrastructure that the NHS has right now has grown enormously in the past few years, and needs to grow even more. This is a race. I do want to reflect to some degree of confidence. So about a month ago, I was up in Leeds at the Cyber Center for the NHS. It is really impressive, I have to say. They use a whole suite of the latest software, and they monitor incursions coming in to the entire NHS. The Leeds Trust has 13,000 desktops and laptops that they manage. 13,000, that's one trust, right? And so think about that spread over the entire NHS. So there is a cyber center that runs out of the NHS Digital, soon to be merged in, that monitors traffic coming in that's trying to create incursions and steal things and disrupt things in a real-time way. I watched them doing this. It is really impressive. They collect the fingerprints of the incursions. They know which countries they come from. I mean, it's a very impressive. You have a cybersecurity background, so you understand this stuff. I'm a GP. I thought it was really cool, by the way. But impressive. It gave me some degree of. We have to be super vigilant and keep improving. But the fact that this infrastructure already exists and is in place and is well managed, I took some solace from. I do need to say, though, that we have to be and will need to be, and there's a hinge here with innovation, which is problematic. So in the US, the incursions into healthcare, most of the time that there's an incursion in healthcare, it actually comes in through a research portal, because researchers use a lot of unsupported software they created themselves oftentimes, and they often have connections into digital systems so they can go in and play. And so I'll just say there's an interesting dynamic here with unsupported systems often being the very people who are doing the most innovation are actually potentially open the most or provide an entry into threats because they're on unsupported systems. So we need to develop some policies and procedures around unsupported systems and decrease the number of unsupported systems, honestly, and find ways to do the patching and upgrades that are necessary to make them fully supported. So lots of work to do. There's another piece of work to do on cyber, which is it's not the incursion that is itself the problem. It's when the incursion shuts down a hospital or an ICU and they've got to deliver care. I've been in a hospital when care was shut down due to an incursion, and it's amazing how quickly clinicians, experienced, highly skilled clinicians, forget how to operate without their computers. And we need to make sure that we are doing the right diligence on downtime procedures and practicing downtime procedures, because there will be downtimes, and we need to make sure that those downtimes do not affect patient care. So I'll speed up now. So interoperability, yes. We need standards. We need to simplify the number of systems that we need to build interoperability between. There's a commercial tension there. We need enough systems so that there's competition, but few enough that we have a limited number of bridges that we have to build. That is, I'll just give one example. On September 8th, Greater Manchester is going to decommission over 300 different IT systems and replace them with one system across 7 different institutions. That is going to significantly enhance care because all of those interoperability bridges that need to be built and maintained are going to go away, and it's all going to be outsourced to a professional company that does that. That's, I think, really good news for patients in that patch. We will always need to build and maintain interoperability bridges, but I'm hoping we can decrease the number of them and expand them so that there's more going through them. So fewer pipes, but bigger pipes. And then the last, so it's not so much about the nomenclature per se and how we talk about the nomenclature here, but it is very much to me about the funding and regulatory apparatus that uses those words and then constrains our options as we innovate. Did I say that? That's really abstract. It's really cryptic what I just said, isn't it? I today was in meetings in which I was looking at legal language around the laws around regulatory IG, information governance issues. And they are constrained because they were written 25 years ago and don't apply to today's technology and information. And yet they are standing in the way of innovation. And it's a real head scratcher because it's non-trivial to change the language. And so what we're trying to do is, okay, can we reinterpret that word? Because it is about the words that we use and the words that we write down. And those do constrain our options as things move forward. So we need to be vigilant about making sure that we don't let words written 10, 20, 30 years ago constrain our ability to move forward with innovation, because that is a big problem, given the requirement for us to address our capacity challenges using innovation.
Sarah.
Okay. So I'm going to start with cyber. So yes, I think obviously, cyber is an incredibly important piece to what we're thinking about. However, I am by no means an expert in cybersecurity, such as yourself. But like Tim was mentioning, and coming back to the conversation around standards and expectation of those standards, we will be leveraging and ensuring and making sure that we are, and the trust that the hospitals that we are building are firmly following the cybersecurity standards that are being set with NHS Digital, soon to be merged. Yeah. So absolutely, but there's always more to do, and there's always more to think about, and continuing to think about the future, and making sure that we always have our eye into the next sort of few years ahead to understand how we can continue to innovate in that space. Interoperability is one. We have 5 design principles, if you will, or themes within the digital work stream within the program, and interoperability is one of those, to ensure that when we are talking about all of these systems and all of these solutions that we're trying to bring together to connect, the interoperability is very much at the heart of that, and is thought about, but in a simple way. And I think that's what you were saying in terms of, it's not about taking 500 different systems and sticking them all together. It's about making sure that makes sense, and it is something that we come back to and is at the heart of what we do, and ensuring that our relationships with the wider, looking at that ICS, and those questions are being asked of that interoperability across an ICS and like now.
The question on
what was the question?
Well, it might be quite a relevant
there.
one. Are we too rooted to the definition of hospital?
Hospital. Well, quite possibly, and I suppose the opportunity that we have is that how can we look at that differently, and how can we look to design the hospital building in a different way, and what does hospital mean? And so I think we do have a lot of opportunities to look at the services that are delivered in a hospital, and how we might be able to move some of, have different buildings for different functions. I suppose that gives that ability to treat the higher acuity within a hospital building, and then move patients to maybe a downgraded building or somewhere else in the community. But again, I think from our perspective within the new hospital program, that's about our relationship again with the rest of the ICS, and ensuring that if we build in such a way that there is then somewhere for patients to go, and so that we're all aligned. I mean, nothing can be done in silos, and nothing can be done in isolation anymore. I don't think it is that longitudinal record and that longitudinal journey that the patient is traveling on. So yeah, okay.
And Tom, in fairness, I think you were the one panelist to mention security threats. So I think you get out.
Can I get my gold star?
Yeah. But have you got any thoughts on that, or indeed the other two matters?
So it's more than just what's coming towards us. Is that a lot of these standards are actually international now, and people are looking to the NHS as one of the clear leaders in terms of who sets the standard. a lot of the people that I deal with from a commercial point of view, then one of the things they're looking at is FDA regulation and making sure that it's compliant with that, because a lot of tech companies don't sell, UK-based tech companies don't sell to the UK because it's just too difficult. And so I would say that this is not just a UK-specific issue, and that if we want to essentially also grow innovation and entrepreneurs, then making sure that our standards are aligned with other people's is a very good first step. What I would say about in terms of branding, then branding really does help and it's important. So we had a particular problem with the area that I'm in because we had ambulatory emergency care, and it turned out the politicians thought that meant care that happened in the back of an ambulance. And I know that's probably not a great thing to say at the moment because there's rather too much of that. But so we rebranded that as same-day emergency care, and that then enabled us to get the momentum behind the program and to get people involved in it. And the last point I would make is I mean, which relates to both of your points and also Tim's thing about it. So the whole of Manchester has only got 300 IT systems that. Because nothing strikes fear into our heart from an IT perspective. Like, I've got an Access database with all my patients on, and that's the problem, is that certainly in these larger organisations, then there is this culture of having your own IT and the control issues which relate to that. But it's how we can work with some of these big suppliers in order to make sure that we can support innovations safely. Is that fair enough?
I'm afraid we're going to have to bring it to a close now because we've already overrun slightly, but I'd like to thank the panellists for their fantastic contributions. It's been a really fascinating discussion to moderate. I hope this has given you a taste for more policy. We've got another event next Wednesday lunchtime on the future of general practice, which will be hosted here, so please do come back for that if you are around. And I'll just conclude with thanking you all for watching and for all your questions, and our excellent three speakers, so Dr. Tim Ferris, Sarah Thomas and Dr. Tom Hughes.